Yeah, thank you, Abhilash. Now, Dr. Arun has joined. I'm glad to welcome Dr. Arun Thomas, an young and brilliant nephrologist from Kerala. He is presently the senior consultant in Believers Church Medical College, Tiruvalla, Kerala. He finished his undergraduation and MD from Kottayam Medical College and Calicut Medical College and had his DM training in Trivandrum Medical College. He has 15 paper publications in national and international arena, and particularly he won the Tanker Foundation Award from ISN in 2019. I chose to bring him here because he has this work and publication on uh, ground reality of assessing the fluid status using ultrasound. And along with Dr. Abhilash's talk, I thought a brief summary of this paper would be a great add-on for this audience today.
Good evening, everyone. Thank you for giving me this opportunity. And now I want to, in 10 minutes time, I'll be discussing or I'll be sharing our experience on integrated lung and inferior vena cava ultrasonography for dry weight estimation in hemodialysis patients. So just sharing the abstract of this original article published by us in 2019. This was a single center study done in Government Medical College, Thiruvananthapuram. The background of the study is the usual clinical practice in our region and also in most of everywhere is to assess the dry weight by clinical judgment, which is very subjective and can be inaccurate. And already discussed lung ultrasound, which can detect the extravascular lung water, that is the extravascular volume, can be useful for dry weight estimation. IVC measurement can also be useful. Here, IVC measures the intravascular volume. And rather than just measuring the IVC diameter, more better or quantifiable measure will be IVC collapsibility index, where expiratory diameter minus inspiratory diameter divided by expiratory diameter. So if you take the IVC collapsibility index, this can take into account the variation of the diameter during the respiratory cycle, and also the cylinder tangential effect, which already discussed, can also be nullified to some extent. And what we postulate is, if we integrate both lung and IVC ultrasonography, this can result in more better dry weight estimation, as lung ultrasound estimates the extravascular lung water and IVC collapsibility index gives the idea of the intravascular volume. The study design is, firstly, we streamlined or we redefined the dry weight of the hemodialysis patients based on clinical judgment, which is a trial and error method. After redefining the dry weight using clinical judgment, 2 weeks, we assess the breathlessness score using NYHA score and orthostatic giddiness score. After these 2 weeks, the dry weight will be redefined with the help of integrated lung IVC ultrasound. And after redefining, again for 2 weeks, NYHA score and orthostatic giddiness score will be documented, and pre-post scores will be compared. Then how to do an integrated lung IVC ultrasound? This is usually, it should be done 30 minutes after dialysis session, so that the equilibrium, the intravascular, extravascular shifts equilibrium will happen. And for both lung and IVC ultrasound, we use curvilinear ultrasound probe. For detecting B lines, we used limited assessment, where we draw a mid-clavicular line and upper and lower mid-clavicular line, and also B lines will be checked at upper and lower mid axillary line, mid clavicular line and mid axillary line. 4 regions in each side. So total 8 regions B lines will be checked. Screen is not moving.
You go to the
yes
extreme.
Then, so the dry weight based on lung IVC ultrasound will be like this. This is the weight of the patient at which the number of B lines are less than 4 on 8-side lung ultrasonography, and IVC collapsibility index is between 50 to 75%. That's the definition we used. And after redefining the dry weight, there was a change in the dry weight from that was defined clinically in 43% of patients. That is, in 34 patients, the dry weight changed. So for 3 patients, the new dry weight was more than the previous value. And for 31 patients, it was less than the previous value. There was no difference in the dry weight in 50.6% of patients. So in nearly 43% patients, there was a change in the dry weight. And with clinical assessment, the patient was actually volume overloaded. This 43, most of these patients, 31 patients, were volume overloaded. And another interesting finding is lung ultrasonography done 30 minutes after the hemodialysis. For 21 patients who had significant number of B lines, chest auscultation revealed basal crepitation in only 4 of them. So this again shows this lower sensitivity of chest auscultation to detect subclinical lung congestion. So this is one image. So this is an 8-side lung ultrasonography of one of our patients taken 30 minutes. You can see the B lines, the total 12 B lines. This is an IVC collapsibility index, which is measured using M-mode ultrasonography. And the parameters which we compare, the breathlessness on post-dialysis, post-HD day, before and after changing the dry weight, there was a significant improvement in the breathlessness. So this score came down. And also score on the pre-HD day also came down in the patients where the dry weight changed using integrated lung IVC ultrasonography. And regarding the orthostatic giddiness score, though the orthostatic giddiness score came down, there was no much significant difference. The p-value was not significant. So in conclusion, symptoms related to fluid overload or depletion were less when hemodialysis prescription was based on lung IVC ultrasonography defined dry weight, and lung congestion in absence of clinical symptoms and sign can be detected using lung ultrasonography. And this is another study. This is on active deprescription program in chronic kidney disease patients undergoing hemodialysis, which is done in Believers Church Medical College Hospital, Tiruvalla. Here, in this program, one of our objective was to lower the number of antihypertensives by obtaining or getting the correct dry weight with the help of integrated lung IVC ultrasonography. And we could get a significant reduction in the number and dose of antihypertensives after redefining the dry weight based on lung IVC ultrasound. So this was the experience which I wish to share to you. So I definitely feel redefining the dry weight, which we get through clinical assessment through lung IVC ultrasonography, can make a significant difference. So it is not a standalone lung IVC ultrasonography. First, it is the dry weight based on clinical judgment, and then fine-tuning it with the help of ultrasound. Thank you.